All right. Well, welcome everybody. It's good to be back. I'm sorry about the technical difficulties I had. That's what happens when someone hacks your computers and your emails, and boy, it messed everything up. So, lot to talk about. I'm not sure what was talked about last week, but boosters, new pills that may be coming out soon. Now they're even talking about a patch that may be out in a few years, but certainly new technology coming about all the time. So let's start off with the boosters. We heard today that J&J this week is going to request their second vaccine, which they're going to call a booster. Moderna is requested it, and the FDA is to meet this week. So let's start, David. You want to talk about the boosters, who's supposed to get them right now, and how that will change when these new EUAs come about?
Yeah, I think, right now we need to remember the only FDA approved vaccine is the Pfizer for ages 16 and up. Everything else, every other indication we give the Pfizer on, which right now would be 12 to 15, and anybody that requires a booster is done under the emergency use authorization. Hopefully that'll change, but right now it's enough. We're getting people the vaccine. Moderna for 18 and over is still on an EUA. They do not have full FDA authorization yet. It's my understanding on the 15th and the 16th, they're going to have a number of different conferences dealing with many different things, Moderna boosters being one of them, which we kind of have been doing Moderna boosters anyway. When they originally recommended the boosters for people who were profoundly immunocompromised, particularly solid organ transplant patients, they didn't differentiate on Pfizer versus Moderna. But Moderna is also going to submit their adolescent data, if I'm not mistaken. I don't know about younger than 11, I think is how far they went down on their study. Said many times my daughter was a member of that study. I don't think they're going all the way down to 5, but I think they have data in the pediatric literature too, Dwight. I may be wrong about that. But, so they're gonna do the booster talk, the adolescent talk, and then I think on October 30th is when Janssen is doing their second dose talk. We'll call it second dose. So and a lot more science coming out. Hey, science is good. More information is good. Let's figure out more about these powerful weapons, how they work, how they make the immune system work, how they prevent COVID, how they prevent people from getting sick. I think all of these things are so important, especially if before Christmas and Thanksgiving and all that kind of stuff, especially if you can open up a new lane for 5 to 11-year-olds and things of that nature, then I think really that's very emboldening for success against the pandemic.
Dwight, what do we think is going to happen with the 5 to 11-year-olds? We know that teenagers, we've had a difficult time getting significant vaccination rates. What about the 5 to 11-year-olds? Is it going to be any better?
Well, I think that right now, as what I heard this week, is about 25% are just chomping at the bit to get their vaccine for their kids. I believe that's right, 25-30%. On the other end of the scale, about the same, or say, no way I'm going to get a vaccine for this. And then you got the middle group. So I wouldn't be surprised if we can hopefully get in close to the 50% range. Maybe that's optimistic initially. I don't know. But anybody we can get vaccines, that's more than we have now. So that's the way I kind of look at it. I think there's going to be parents that are, just as they were skeptical for themselves, they're going to be skeptical, if not more so, for their children, even though everything looks good. Their concern is, well, children may react differently. I think if my opinion is they'll probably do better than the adults in handling it. I mean, their kids they're tough, and I think they'll do fine. Certainly with Delta, we've seen such an upsurge in numbers, well over 5 million cases now in children, lots of hospital stays. death rate around in the 500s probably at this point. It was 480 last week, so I'm guessing that I didn't see the data tonight. So, but it's definitely affected the children more. It's definitely affecting the schools and everything. So I think we'll probably see about 1 in 4, maybe we'll get a lucky 1 in 3 starting out, and then maybe move that on up. Will we get up to the 75-80% range? I don't know. It may take a while to get there. So that's what
I think it's going to be a little more difficult arguing with parents who say, I just don't trust it. The numbers that were studied are certainly much lower in the kids than they were in the adults.
Yeah.
We've got literally hundreds of millions of doses that have been given around the world to adults, but we don't have that yet in children. So I can understand parents being a little reluctant. On the other hand, we've also seen this horrible upsurge in children getting infected, being in the hospital, deaths in children that just shouldn't happen. And so I'm hoping that parents like my parents in the 50s, when the polio vaccine came out, they just said, we trust science. We hope that people will trust science, trust their doctors, and not politicize it, not just say no, listen to their doctors, and hopefully the pediatricians around the country, especially in the state of Oklahoma, are going to be encouraging and knowledgeable so that the parents do go ahead and get their kids vaccinated. I saw a statistic today that I was very encouraged about, surprised, but encouraged. Oklahoma County has over 80% people with first shots above the national average. Kudos to our mayor. Kudos to the people of Oklahoma County. The rest of the state needs to follow, but that's tremendous.
What a huge accomplishment in this state.
Absolutely.
To get over 80% of adults vaccinated in the Oklahoma City metro area. I mean, that is, really encouraging. And hopefully, as more people here in the city who have friends in Lawton, who have friends in Ardmore, who have friends in Enid, talking to them, we're all fine. Everybody's fine. Nobody grew a third horn. I mean, all of these kinds of conversations kind of coming back around the kids. I think that I don't know exactly, but I'm thinking in Oklahoma, it's not quite 30% of 12 to 16-year-olds are vaccinated.
That's pretty close. It'll be
interesting to see what happens if they drop that age even further. But the other thing we don't know is, are they going to bring more information to the FDA about what they've seen in that 12 to 16-year-old cohort too, that maybe could bring that up a little bit? Because I mean, that's a sub-segment that you really worry about. I mean, the 12 to 16-year-olds are much more likely to be out and socially active really than the 5 to 11-year-olds. So I think seeing that increased vaccination rates there would only be very, very encouraging to maybe those little brothers and sisters, to make them feel better about getting them vaccinated too. But again, even I mean, I would love for it to be 50, 60, 70%. I would love for it to be 95%. But even if it's 25%, those are real numbers. That's herd immunity, and that's kind of driving it there. I don't think it's enough. I think I encourage, as I'm sure you do, Dwight, every parent be a responsible member of society. Every parent be a responsible advocate for your child, and go out and get the vaccination, because it does make a difference. And there are children, and we're not trying to fearmonger, but there are children in the hospital, and you don't want it to be your kid. That's all there is to it.
A couple things that I've said before, and I'd like to mention again. We want kids in school. First of all, that helps. We want them in school because they learn. It's better for learning. We've got the testing stuff. Of course, the testing stuff may be biased because of who got tested this last year. We had some drop off, but so that remains to be seen. But also, if they're in school, then mom and dad are at work, and we have a little bit more normal lifestyle. Things are going better in general, rather than having to stay home. That's it. But also, more importantly, and the thing that I've worried about all along, we have seen cases where people have had a mild or just hardly very little anything, ending up with post-COVID symptoms. And what is that going to do for these kids, that particularly the smaller kids with developing brains? Are we going to see things post-COVID that we might not have seen in adults? I worry about
Who
that.
knows?
Maybe that's being paranoid. I don't think so. It just we need to encourage folks to go for it. I think the likelihood, everything, there's some risk, but the risk to me is far less if people will get their kids vaccinated. And it's turned out that way with all other vaccines, and this one even seems safer to me than a lot of the vaccines that we've introduced in past years. So I think we need to go for it. I feel good about it. The grandkids are going to get it, and I wouldn't blink an eye on it. So
I would blink an eye. No,
Yeah, my grandkids are getting it as well.
Yeah.
They don't live in this state, but I've talked with my daughters, and they're excited that hopefully, the vaccine's going to get approved or get EUA, and they're looking forward to it. They're in school with masks on right now, and they're scared to go anywhere with their kids just because of the number of people who aren't vaccinated. And there's actually an interesting study that came out that showed that people who are proposing, I just want to get natural antibodies. I want to be, get sick, and then I'm going to have all these natural antibodies, and that's better. It actually has shown that they are twice as likely, if they had the alpha or original variant, they're twice as likely over that fully vaccinated to get COVID again. And especially with the Delta and other variants that may be coming out in the future, that's not the approach. The approach is truly through vaccination, and people need to understand that. But there's been a lot of information that's come out this last week or 10 days on a new pill. Merck, there's actually 3 different ones being developed, but Merck seems to be leading. They're in phase 3 trials now. A new pill to treat COVID. And I've heard all kinds of rhetoric from people, not doctors, who say, I'm going to take the pill. I'm not going to get the vaccine. I don't know what's in the vaccine. Well, I hate to tell you, but you don't know what's in the pill either. And David, can you talk about the new pill and what the indication is?
Pronounce it for me first. How do you pronounce it? I looked at it today and I've already forgotten.
I forgot.
Maybe I put you on the spot. I'm sorry.
Remdesivir or something.
It's molnupiravir.
Okay.
It's a ribonucleoside analog. It was developed at Emory. Emory has been at the vanguard of COVID since day one in the United States. Of course, Emory is located right across the street from the CDC, and as I understand, has the finest undergraduate program in the country. So,
David, where'd you go?
Did I not mention I went to Emory? I'm sorry, I didn't mention it. But they've got some excellent. Actually, one of Oklahoma's finest, Dr. Mehta, has been leading the charge against COVID since the beginning. His father was a physician here, and he's an ID doctor there, a transplant specialist who got early on involved in remdesivir. And I have no doubt that I'll be texting him with the next 2 or 3 days to ask him what he thinks about this drug, because this developed at Emory, kind of, but sort of shepherded through Merck, because Merck, of course, has that sort of machinery to be able to do that. It's a ribonucleoside analog, and what it showed was about a 50% reduction in the likelihood of death. They had about 700 patients enrolled. Half got placebo, half got this. They were enrolled within 5 days of diagnosis of COVID. They had to have at least one risk factor for hospitalization. So they had to be at least 60, at least diabetic, at least fat, things like that. They showed a 50% reduction. 7 people in the treatment arm out of 355 went to the hospital. 14 people in the placebo arm out of the same number went to the hospital. 8 deaths in the placebo arm, 0 deaths in the treatment arm. So they actually moved it up early. This was the first primary analysis that went to what's called the Data Safety Monitoring Board. This was the first primary analysis, and it was compelling enough that they decided to go ahead and try and move it through for an EUA. So I will be fascinated to watch this presentation to see whether or not they get, and I'll bet they do. Now, what does that mean? Does that mean that this is a substitute for the vaccine? Not even kind of. Does that mean that this is another weapon that we can use in armamentarium? Yes, of course. Does this mean that it replaces monoclonal antibodies? I'm not even sure I'd say that. I think monoclonal antibodies have been the real unsung hero of the entire COVID experience here, because it was still a lower hospitalization rate. 7% of the hospitalizations in the treatment are at this study. But if you compare that to monoclonals, about 3%, 2.5–3% hospitalization rate, monoclonals probably still outperform this. So it'll be interesting to kind of see. Now, it's a pill. You don't have to go to the hospital. You don't have to get infusion, blah, blah, blah. I get all of that stuff. But for the right patient, it's just one more thing that you can put in your quiver to try and battle. So it'll be great to see. I love seeing more companies getting involved. I mean, this is the kind of stuff, that all those big pharma companies, they always talk about how their drug prices are justified because they're pouring it into R&D. Well, this might be Exhibit A, because I've always thought it's a pretty hollow argument. But I think that this is the kind of stuff that only happens with billions of dollars and billions of dollars in research. And we'll see what it shows. We'll see what they say.
Yeah.
It's always one thing when you read about it kind of in these squibs and everything like that. But talking to the studio audience here, not to the other panelists, but there's a way we read literature that is very critical. That is very when Larry or Dwight or I read a paper, we're really kind of looking at trying to punch holes into it. So I'm really interested to see the real study paper and not just these sort of squibs that they put out there in the ether in some of the trade circulars, I guess you would call them. I don't know. I mean, I really want to see the hard data. And so you want to make sure the groups are equal. I mean, there's all kinds of different things that go into it. So we'll see what it shows, but they must feel pretty good about it. And Merck certainly has developed a drug or two. They know what they're doing. So they must feel pretty good about it that they're already submitting it to the regulatory authorities.
Well, I was encouraged that at least the information that's come out, and nobody's read the actual data, but the information that's come out not only decreased hospitalizations as well as deaths. What didn't come out, the treatment's going to be 4 pills twice a day. So that's 8 pills a day. And nothing was said about cost. And I don't know that the government's going to absorb that like they do.
$700 is what I heard.
Did you hear that?
Mm-hmm.
I hadn't heard.
I heard $700 for a course of treatment.
So, I mean, I think there's things that we still need to come up with. But I do think for a lot of people who may be scared of shots, who, for one reason or another, don't want infusion, but taking a pill they're willing to do, it's another gun in the arsenal to try to prevent people from being hospitalized and, most importantly, from dying. So I think this pill could be a huge, huge step forward. And as I said, there's 2 others that are in stage 2 trial. One of them is going through stage 2 and stage 3 at the same time. And so, within a year, we could be seeing several things coming about that are going to be new to try to get this pandemic back under control. I think that's important. Dwight?
Well, this kind of reminds me of what we used with influenza with the Tamiflu, and it's just another weapon in the armamentarium. But the biggest thing obviously still remains the vaccine and the monoclonal antibody. I think is those are the things we're going to talk about. And one question I had, and maybe you've already answered it, I missed it. Is it going to be one of those things where you need to start it within the first 48 hours, or forget it, or can you start? The
recruitment was done within the first 5 days. So the Tamiflu, the oseltamivir studies were done within 48 hours of symptom onset, and I would submit, that was that was one of those ones that barely got through the FDA on very thin data. Yet the oseltamivir, I believe, the only thing it showed was a reduction of symptoms by 1/2 of 1 day, and yet it made it through. And my fear is a little bit, and we saw this every time anybody ran a fever, they throw oseltamivir at them, and it was like, well, what ended up happening? Predictably, influenza became resistant to it. So you want to make sure that molnupiravir is being used appropriately, and if it's on an EUA, it should be more policed in terms of you have to get consent from the patient and everything like that. So if they release it on an EUA, my guess is you will have to show proof of a positive test. You can't just throw it at somebody with a fever, which is what we saw with Tamiflu. And you want to make sure that it's used appropriately as much as possible. How much they have out there, I have no idea. How much they're going to give to us, I have no idea. Is it going to be on an allotment? Is it going to be like, I don't know. But again, just one more thing that might work.
Yeah, I mean, the study was very clear within 5 days of testing positive, but you had to test positive. It can't be just given to somebody who thinks they might have been exposed. And hopefully doctors will follow that and not go off script. So that's going to be important.
Because we would never do that with, say, an anti-parasitic or an anti-malarial. we would never do anything like that.
Yeah, I was just going to come up with talking about ivermectin. I don't know if you saw the article that a judge in Montana actually ruled in favor of a physician in a hospital who refused to give ivermectin to a patient who was dying of COVID, saying that there was no indication and that doctors and hospitals were not obligated because the patient or the patient's family was demanding it. And for the first time, we've seen so many laws go against medicine in the last few years. I was just so pleased to see that a judge finally stood up for the doctor and the hospital.
Haven't we had some go the other way, Larry? That's what I was thinking.
We had the Kentucky one where they said, but then another judge, overruled it. You've had a few. You've had a few like that.
As I say, we've seen those. This is the first time in a long while I've seen a judge stand up and say, let's use common sense, folks. The doctors and the hospitals know what they're doing. Let them do what's right. It may not work. I'm not saying that every patient's going to live. We know we've lost 700,000 plus. We've lost 10,000 in this state. So, but we know what good medicine is, and good doctors need to be able to practice good medicine. So that's my little, get on my soapbox and spiel. I was going to say before we pass over and I forget, Dr. Mehta at Emory is the son of Dr. K. Mehta, who was a past president of the State Medical Association. And I was honored to work with him and to know him as a friend and a peer. And we're proud of Dr. Mehta. Very proud of him.
Anish, I want him to come home. He knows I want him to come home. But he has been he'll be on the Hall of Fame for all this stuff. So Emory's done fantastic work. Obviously, they have a pipeline to the CDC, so they're able to get some things that maybe other places aren't going to get. But it's a fantastic hospital system, a fantastic medical center. And I just think it's so cool because you really don't see that, right? We really don't see universities developing their own drugs. And they had a program called DRIVE. I think it's Drug Research and Initiative and Development at Emory, DRIVE, that is specifically geared towards trying to find new drugs and research, using the research that they're doing at Emory, compelling them to make new drugs, and then getting with these other partners that are able to help them get it over the goal line. So fascinating model, and one that really makes a lot of sense if you think about it. When you want the drugs being developed there at the research institutions, where the doctors are able to kind of go from the bench to the bedside, to really be able to shepherd those things through. So I don't know that Dr. Meadow is involved with this, but I'm going to knowing how much he's had his little finger and everything else, I got to believe he was on some level or another. So, but yeah, his father, Dr. K, had a heck of a vascular surgeon in the Saint system for years and years. Just a real doctor's doctor, real gentleman, very nice man. Always very nice to me as a young doctor coming up.
We need to try to get Anish on this program.
Yeah,
Let him talk about it.
I will.
Oh, that would be great.
Yeah, it's good.
Yeah, give him a call and let's see, because he knows several of us. I'm sure he knows Dwight. He certainly knows me. So
I know his father. I don't know if I met Anish, but I would love to have a conversation, or we have a conversation.
Super smart kid. Super smart guy.
Yeah, he is. So, well, at this point, it's unfortunate that because we don't have questions, we don't have the audience to give us questions, because I'm betting there'd be a lot of questions about the children, the boosters, the pill. But I'm going to bring up something that I just heard tonight. I know nothing really about it, but I think it's a tremendous idea. And that's the new study that's years away. I want to emphasize that this is not something coming out tomorrow, but using a patch. And the patch has these little micro needles on it that you don't even feel, and giving the vaccination that way, where it's kind of gradually given over time, and supposedly from the initial studies being done at Stanford, tremendous results. So have either of you seen this patch or heard about it?
So it's a vaccine patch?
It's a vaccine patch. And they say because the immunologic system of the skin, of the dermis, is far greater than muscle, the response is tremendous with this. And they said you don't even feel it.
Well, it's not like we haven't looked at that before. Do you guys remember about 10 years ago when Chiron Pharmaceuticals had a huge problem with influenza production, and we lost like 100 million doses right off the bat? Do you guys remember that? Anyway, it was a big pharmaceutical contractor that the United States bought all the. Anyway, the whole thing so all of a sudden we were down to like half of it. And so they did a really robust research on giving quarter doses of vaccines intradermal instead of intramuscular, and showed a very robust immune response that way. It makes sense that the skin has a fantastic immune system, right? I mean, that's what IgD lives in the skin. I mean, because the skin is exposed to more microbes and icky crawlies and everything else than any other organ in your body except for your airways. So it makes sense that that's fascinating.
That is fascinating. How long did it on? Did they say? Do you have any information?
I saw a small blurb about this, and cool. I've not seen an actual study or anything. And they said it may be up to 5 years away from, being out in the public. But the idea is, and I think it probably stems from what David's bringing up, where we used intradermal before. We all know that the dermis is much richer in immunologic status. So it makes sense to me. Yeah. And the fact that it's not a shot, people aren't going to be afraid of it. It's a patch that they put on. I don't know how long you leave it on, but I think it's a tremendous idea. So,
anything we can get to get more vaccines. I mean, if you, that's the funny thing though, as you continue to come at the anti-vaxxers with information that goes against what their deeply held beliefs are, it's like, well, it's not FDA approved. Well, it's FDA approved now, but you're still not getting the vaccine. I'm scared of a needle. Well, is a patch going to fix that? Maybe it is. Maybe it won't. I mean, they're going to find another reason not to get it. It's like, I don't want the glue on my skin. I mean, whatever it is.
My feeling is that you don't get the vaccine, you don't get the patch. Well, then you probably are going to get the virus. So, you have your choice. It's a free country. So be it. I did want to say, when we talked about boosters, and we didn't bring this up, but the Moderna booster, we've brought it up before, may be a half dose. Yeah. So people shouldn't, it probably won't hurt, but people shouldn't just be going out and saying, give me a third Moderna shot, because the booster may only be a half dose and give you the robust response that we're looking for.
Yeah.
And I think that's real important.
Well, if you think about it, if you've had 2 Moderna shots in your primary series versus 2 Pfizer shots, with the Moderna, you've had 200 micrograms of messenger RNA versus 60 micrograms. So you've already had 3 1/3 times the dose that Pfizer folks have had. And that may be the reason for the more prolonged antibody response. We still don't know what it means in terms of rehospitalizations and everything. But I fully expect, Larry, that this will be part of the data they present here in the next week or two when they start talking about boosters, because they have been looking at the 50 microgram dose to try and see what sort of anamnestic response you get off of that. And I'll bet it's going to be pretty good.
So I read one study that it was tremendous. It was actually a higher response than what Pfizer got with their third. And it may have to do with dosages, but it also has to do with the fact that Moderna maintained its effectiveness much better than Pfizer did at the 6-month interval. So it's starting at a higher point, and then you get a half dose above that.
Exactly.
So
one question I have on that, with flu vaccine, when we get 65, we bump the dose up, we give a stronger flu vaccine. Do you think has there been any mention about age relation or risk factors, underlying risk? I don't know if that would make any difference or not.
No, not that I know of, that they've looked at it age related. I mean, the way they've rolled out the boosters, though, and this was a big point of contention at the CDC, obviously, recently. I don't even know that we talked about this last week, Dwight. Maybe we did, but that there was, we did talk about it, that there were 4 areas where they totally agreed on the boosters. The one area where they didn't really agree on it was the 18 to 49-year-old cohort that was already fully vaccinated. Was the risk of myocarditis ever so slightly higher than the risk of hospitalization from COVID in a person who was COVID naive but double vaccinated? And so already there you saw that they were recommending boosters for those over the age of 65. They were recommending those. They said people who are over the age of 50 with certain medical conditions should get a booster.
Right.
People aged 18 to 49 with certain medical conditions may get a booster. So already there, you're already reading into that there's some age-related discrimination on who should get a booster and who shouldn't. And that's probably appropriate. I can tell you, as a practicing physician, the people that I've seen that were vaccinated that had ended up back in the hospital, the vast majority of whom did not end up in the ICU, thank God, were over the age of 65. So I think it makes a lot of sense in that cohort. And so there has been kind of that breakdown a little bit.
And one of the factors that has been talked about and probably is related is that the over 65 were one of the early patients to get vaccinated.
Right.
So they've gone 6 to 8 months.
Right.
Now.
So you may not know.
Yeah. And so their immune response may be slipping. And that's why they really do need the vaccine. Exactly. Whether it's a half dose Moderna, a full dose Pfizer, or a second dose J&J, they need something to bring them back up again just because of time. One of the questions I have, and I'll throw this out to both of you and see if either one of you has a answer, is we're in the flu season. Dwight, right now, flu vaccine needs to be given. David knows that as well. Do you recommend to your patients to separate taking the flu and the COVID vaccines? If so, how long? And if not, can they be taken the same day? I don't know the answer to that. I've had one patient who took them both the same day and got really sick.
Yeah, I think that's a risk. I have seen that has been done where they're giving it the same day, but with the precaution that, hey, you may have a more robust side effects as a result of that. Saying that, and I don't, David, I don't think we're seeing much flu yet. Have you seen much in what you're doing?
No, I haven't seen much flu. RSV's actually taking a little bit of an upswing, but I haven't seen much flu.
But as we all know, flu can be hardly going at all, and then within a couple of days, you're wide open. You know, it can hit you and blindside you. So, I think the answer is yes, you can do that.
We have done it. I can tell you, you know, we were recently doing our physician appreciation days where we kind of always go out and give our vaccines, and we were offering both at the same time. When COVID vaccine first came out, part of the EUA was that you had to wait 14 days to have any other vaccinations.
Yeah.
They backed off of that when it got the EUA for kids 12 to 15 because they recognized they wanted a lot of kids vaccinated for COVID who might also need back to school vaccinations. Right. So they backed off of that. Now, all of that being said, can COVID make you feel bad if you get your second and third? There was a good study that came out the other day that showed most people feel about like they did after their second vaccine, after they get their third vaccine. That has been my experience, that most people feel about the same. And I tell them that when I give them the booster. I was like, hey, you're probably going to feel about the same. The other thing I would say is that, you know, sometimes people do react to the flu vaccine. No, they do not get flu. They have an appropriate immune response. If you do both of those at the same time, is it possible that you could feel worse? Yes, it is possible. But that being said, we are always trying to get people at that interface with healthcare when we have an opportunity to get them vaccinated. And if someone comes in and wants both at the same time, if I got a patient that says, I'll come back next week for my flu vaccine. Yeah. And you know, and if people are asking me, if it's a first-time patient who hasn't had a COVID vaccine, you're darn tooting. I'm going to get their COVID vaccine. If I have to wait a week on their flu, that's fine. Right. But I'm going full board getting them their COVID vaccine. If it's somebody who's coming in for a booster, you know, it's kind of like, well, I think it's important that you get your flu vaccine. We're only at October 4th. We haven't seen significant activity. That being said, flu tests are way down. We may just be missing it, right? Yeah. We're going to start seeing more when the testing changes because it's complicated, but essentially the testing kits change a little bit this time of year. The distributors give these tests that test for all three at the same time, flu, RSV, and COVID, as opposed to just having the single cartridge COVID test. So we'll certainly uncover more flu here pretty quickly. I think you'll start to see numbers go up.
You know, we deal with this all the time in pediatrics. You know, there's some visits there where we're handing out or we're doing 3 or 4 vaccines at that particular visit, 12-month, 4-year vaccine. There's different ones where you.
That's a great point.
And we have parents with different philosophies on it. Some say, "Oh heck, let's do it." I mean, we can do them all at once. Get the reaction. If it's going to react, I'd rather do it once and have it over with. And we encourage them just to go ahead and get the vaccine, and that has worked well by far over the years doing that. Others, in order to get them to vaccinate their children, they say, "I want to divide it up." Fine, let's figure out a schedule here. We'll divvy it up. You know, you may run the risk of having more, you know, dealing with side effects more often. But I wouldn't be surprised to see the same thing here. I think there are going to be some parents that say, "Yeah, let's go for it," and then there'll be others that say, "Well, let's do this, and then 2 or 3 weeks I'll get the flu," and that sort of thing. The problem with that, of course, is compliance. You know, you have good intentions, but you get busy and you go, "Oh, crap,
life gets in the way."
Yeah, I didn't get the vaccine, and you get caught up in caught ashore because you get, like with anything else, the flu, you need the vaccine in for a while to have good effectiveness from it. So that's another issue altogether. So.
Well, I think that's important for our listeners to know because there's a lot out there who are going to be wanting to get the flu vaccine and also a booster, and the kids. You know, we're going to be having hopefully soon a lot more children getting vaccinated, and with flu season here, RSV, whatever. But certainly the flu vaccine is going to be common. So I think people have that question. I know it's been asked of me several times. And I'm not an infectious disease doctor, so that's why I bring it up here.
Well, I'll tell you, if I had not had my booster and my flu vaccine, I would not have any problem getting them together. Me personally, that's me. I mean, I'm just as well. I'm all about get the shots out of the way. I can remember when I was in Africa years ago, I get 8 shots at one setting, and that may have been a little too much, but you know, 8 shots at the same time. I had to go play basketball that night. It did not go well.
You were never in the military. In the military, you get them like that. Trust me, I got a scar that tells me.
I believe you do. I believe you do.
So, well, are there
Yeah.
any other major points to bring up this week?
You know, I think it's significant that the state went over 10,000 deaths.
That's one in 400 of our citizens are not with us anymore.
Yeah.
It just amazes me. And you know, I was talking to I went to an event downtown last night, and I got to talking to a gentleman, and he said, "Oh, this is really not a big deal." I said, "Yeah, it is a big deal. I mean, 1 in 400. I mean, it's just it's amazing, unprecedented, and it's sad.
It's a sad benchmark.
Yes, it is.
We didn't lose this many in the wars.
No.
You know, there was no reason to lose it in this war.
Yeah.
So,
and it doesn't compare. I mean, fatalities from auto accidents, anything, that's always a tragedy. But you're looking at the numbers. This is unprecedented. You know.
And preventable at this point.
And preventable. That's the point. Yeah.
Yeah. We encourage people, go get the vaccine. Don't worry about pills. Don't worry about patches. Go get the vaccine. It's readily available out there, easy to get. No longer have the excuse that, oh, I got to make an appointment. No, it's not available to me. It's out there. It's everywhere.
Get it.
And, you know, and it's free. You can't even complain about the cost. So,
right.
Well, I don't have anything else this week, but I think next week, hopefully, we'll be seeing some new information that's come out from the boosters, and hopefully we'll see a continued decline. I know that that's been a big point the last week, a decline in hospitalizations, a decline in the number of cases. Hopefully we'll continue to see that and improve and give us time to get more and more people. I'd love to see Oklahoma County be at over 90%. So
let's get there.
Yeah.
So I want to tell our audience we really appreciate you tuning in for this. We'll be back next Monday, as long as Mr. Zuckerberg doesn't have any more problems. But it's been quite a day for us, but also a day for him.
First Bookman and then Zuckerberg, right?
That's exactly right.
In that order, it should be.
I think Dr. Bookman's issue is solved better than it's going to be easier to solve than Mr. Zuckerberg's.
Yeah.
All right. Thank you all for joining. Dr. Armitage, wherever you are, we'll look forward to seeing you next week, and we'll see our audience next Monday, 7 p.m. for Health Watch Oklahoma. Thanks, everyone.
Thank you.
Thanks.
Thank you.